Hello, everyone. I'm Ron Rolfing, your host of the ACAP Preferred Vendor Education Series, and I'd like to welcome you to our latest session presented by ACAP Strategic Ally Pop Healthcare and Mcara Health. Our presenters today are Allison Unger, Chief Sales Officer at Pop Healthcare and Mcara Health, and Namita Dukaran, National Medical Director of Behavioral Healthcare Solutions at Mcara Health. And they will be presenting the session, Improving Overall Patient Outcomes with Integrated Behavioral Health. But before we get things started, I do have a few housekeeping items I need to take care of. This call, along with all ACAP calls and webinars, will be held in accordance with the ACAP antitrust guidelines. And these guidelines can be viewed on our website. We will be recording today's webinar, and we'll post the slide deck and recording on our website by tomorrow morning. And the link to these items can be found in the invitation sent to you for this webinar. And please remember, if your plan is looking for a vendor, be sure to check out our list of preferred vendors on our website. Just look to the top of our homepage and click on the preferred vendors link. You can also post a note or even an RFP on the preferred vendor connection portal. And of course, during today's session, you can ask a question at any time by clicking the Q&A icon in your Zoom window and typing in your question. And all questions will be answered at the end of the presentation. Now, I'll pass it over to Allison to kick it off.
Thank you, Ron, and thank you guys for joining us today. As Ron mentioned, I'm Allison Unger. I'm the Chief Sales Officer for Pop Health and Mcara Health. I joined the organization about a year ago, spent most of my career in healthcare, but really came to this organization because of the passion and the work that we're doing to really bring care to the home, integrated care to the home for those who need it most. I was a caregiver for my father for many years and sort of experienced the need for this type of care in the home setting. So really my passion is on in-home care and an integrated model. So happy to be here alongside of Dr. Namita Dukaran. Not only is she an amazing colleague and person to work with, she has really interesting and relevant background to the topic in our conversation today, and also a lot of passion behind the topic for today. A little bit more on Dr. Dukaran. She is a board certified internal medicine and addiction medicine, and has a myriad of experience in the care and clinical treatment of people living with mental illness and substance abuse disorders. During her career, she has held both frontline physician and clinical leadership roles in a variety of settings, including outpatient, residential, dual diagnosis addiction treatment centers for opioid and alcohol use disorders. Dr. Dukaran completed an internal medicine and preventative medicine residency and general internal medicine fellowship training at Boston University. She holds an MD from the Joint Dartmouth-Brown program, a Master of Science in Health Services Research from Boston University School of Public Health, and a Bachelor of Science in Chemical Engineering from Massachusetts Institute of Technology. So happy to be here with Dr. Dukaran. Before we get started with sort of questions and just really Dr. Dukaran's perspective on integrated behavioral health, I'd like to give a brief introduction to Pop Healthcare and Mcara Health and the work that we are doing. A little history on Pop Healthcare. We are an organization that's been around for about 15 years, over 15 years. We got our roots in the risk adjustment space. Really performing work for payers to look, do chart retrieval, coding, and a part of that risk adjustment suite going into the home for assessments. About 8 years ago, we realized that going into the home, there was a need to deliver care, specifically primary care in the home for this population. So we started delivering primary care in the home setting about 8 years ago. That brings us to where we are today. So Pop Healthcare, we still deliver risk adjustment solutions to our clients. And then more recently, we launched a brand as a national provider group in value-based arrangements, Mcara Health. So Mcara Health includes a suite of in-home assessments, advanced primary care, and SDOH interventions. So a little bit more about Pop Healthcare and Ankara, who we are, what we do, but really want to get into the meat of the discussion around integrated behavioral health. So with that, Dr. Dukaran, thank you for joining us today. The first question I have, really to sort of kick off today's session and as a starting point, can you help us level set by really defining behavioral health, as well as what do we really mean by integrated behavioral health?
Thank you, Allison. In terms of thinking of behavioral health, different people, when they hear that terminology, think different things. Sometimes individuals think behavioral health, we're dealing with individuals who have challenges with certain ways of conducting themselves, but I think it goes beyond that. This is about behaviors that may affect someone's journey towards overall wellness. And those behaviors could be things related to diet, exercise, so it could be related to unhealthy mental schemas that affect how people respond to different situations, or they could be actual diagnosed mental health or substance use disorder conditions. So I'm thinking very broadly of when I'm saying behavioral health. And in thinking about integrated behavioral health, it in some ways is a terminology that already by itself, it implies that from the get-go, behavioral health is not historically has not been considered part of core whole person health. It's a separate, it has been separated, it has been artificially siloed. And so in thinking about integrated behavioral health, I'd step up a little bit to say, what is integrated care in general? And saying that the focus really there is whole person, team-based delivery of care and care management, and bringing together the mental health and the physical health, addressing the different factors that are influencing someone achieving their wellness goals in the bio, psycho, and social realms. And as we address those things and emphasize higher quality of integrated care, the goal is to improve access, quality of care, have more cost-effective use of our healthcare dollars, and enhance and empower our individuals that we're serving to live the fullest lives possible that they can. And in this context, we're focusing a lot on the primary care setting. And in that setting, integration of behavioral with physical increases access, decreases stigma, increases opportunities for multidisciplinary collaboration, especially in our home-based care model that we have in Ankara, to address the bio, psycho, and social factors that impact a person's overall wellness.
Yeah, makes sense. So you mentioned, traditionally behavioral health being sort of siloed and not truly integrated, but we've been talking about integrated health for some time now, and it really hasn't taken hold more broadly. So, why is integrated behavioral health better positioned to stick now versus, kind of just talking about it for a while now?
Well, Allison, that's a little bit of a complicated question. I think that we are in a better place than we were before. I think we still have some ways to go. So while we've been talking about integration for some time, I think the things that why now we are situated better to integrate successfully is there's a greater awareness of the extensive published data out there on the gaps in care and potential solutions in integrated care. So gaps, I would say, for example, we have 46% of American adults will have some sort of mental health condition within their lifetime. The second leading cause of death in 10 to 34-year-olds is suicide. A small minority of mental health systems are using evidence-based interventions in routine care. A small proportion of psychiatrists and psychologists routinely use measurement-based care. And folks who do access mental health services, if they can get them, 1 in 5 clients I saw in one place drop out of therapy just after the first session. And so the data is there, showing where we have gaps, and then there are areas of opportunities. In 2020, Milliman came out with a research report, and in that, the most expensive 10% of the 21 million population accounted for 70% of total healthcare costs. And of that top 10%, 57% of them had behavioral health conditions. So when you break it down, those folks with behavioral health conditions, they actually are 5.7% of the 21 million population, and they account for 44% of the total healthcare costs. So with repeated literature showing these things, it even brings it more to the surface that this is something that we need to address. And then in the midst of that, there's a lot of literature about solutions. So back in 2008, for example, there was the impact trial of depression collaborative care for older adults. So that's embedding a behavioral health care manager within the primary care setting, and had a lower mean total healthcare costs compared to those who got traditional care for depression in the primary care setting. And it showed that up to $6 are saved in the long-term healthcare costs for those patients for every dollar spent in that collaborative care model. So an ROI of 6 to 1. And so while we may do some good with treating even just simple depression in primary care, we do have opportunities to do better. So all in all, I think folks, not just on the clinical side, but on the business side, are starting to really see the great value in pushing forward integrated care for overall quality of care, as well as a more efficient use of our healthcare dollars and resources. People are seeing it as a social and a business imperative to move forward in this direction. So I'm optimistic in that way, but at the same time, one of the major barriers still is how we finance healthcare and trying to figure out alternative payment models that encourage integrated care. So that is still a work in progress.
Yes, for sure. So you mentioned some of the data and literature, putting a spotlight on the need for integrated behavioral health. What do you think, the experience of the pandemic revealed about the need for this type of integrated care?
So, when I was looking up the data again on this, I actually saw some data on a global level. WHO cited that there was a 25% increase in prevalence in just straight up anxiety and depression across the world in the midst of the COVID pandemic. And because of the concerns for potential increase in mental health conditions, that prompted up to 90% of the countries surveyed by WHO to include mental health and psychosocial support. And even with that, as part of their response plans to COVID, even with that, they still had significant gaps. And then we've also heard about drug overdose mortality rates spiking up in the midst of COVID in the US. And I was actually thinking about it. It kind of reminds me of the person who has a substance use disorder, say an alcohol use disorder. They go to work, they might even have a very successful career trajectory, doing well. And on the surface, everything looks okay. They're functioning okay. But when crisis hits, the underlying foundation and infrastructure of their lives is stressed, and the cracks show. And I think the pandemic was kind of like that. It was this society that seemed somewhat functional on the surface, but had a mental health crisis that was preceding the pandemic, couldn't hide it. And it came to the surface even more. And we could react to that. I hope we actually use it as a catalyst to say this crisis that was there before, it's not going away. And if anything, if we get hit with further crises, we need to build resiliency, coping skills. We need to focus on prevention, earlier intervention, earlier screening, identification, and get people the care they need before they end up 10, 20, 30 years from now having adverse outcomes in their physical health as well as their mental health.
Yeah. And so, now we are here, I would say somewhat post-pandemic, hopeful that we're post-pandemic. And so between the data, the pandemic itself, huge spotlight on behavioral health at the forefront. But we're also dealing with serious provider shortages, especially in behavioral health. So how can we think about successfully implementing a model like integrated behavioral health for a plan's most vulnerable members, given the provider shortage, and just, how you would go about integrating this for these populations?
I think that has to be a multi-pronged approach, but recognizing that if a health plan is, depending on where they're at in this journey, they may or may not have the infrastructure resources or even the readiness for change within their organization to take this on. And in terms of the different realms to consider, some collaboratives out there have done some studies funded. For example, one was by RWJ, and they looked at a series of domains that could be addressed, and organizing the movement. So like getting us all to talk to each other and share what we're doing, and not just this person here and this person there doing different things. Force education and training. And when I say that, not just our specialists, but our primary care providers. There are lots of opportunities there. And even the providers that we do have, while we do have a shortage of behavioral health providers, the ones that we do have are not necessarily most effectively utilized or leveraged. So helping our providers, building our capacity within primary care to treat some things that, to screen more effectively and more routinely, and perhaps build capacity to treat better with more quality metrics in there, anxiety, depression, and I would love to see increased capacity to treat opioid use disorder and alcohol use disorder within primary care, and I'm a believer. And beyond that, also having more care management capabilities. So we not only have a PCP as a physical health care manager overseeing the care that they provide directly or coordinating with specialists, but behavioral health care management side by side in joint treatment planning. And that's the model that we are building in MCARA, is doing that so that it's not siloed, that you press a button and refer to behavioral health and maybe the person gets connected to somebody. And even if they get connected, that person doesn't have sight of how their chronic pain is affecting their depression. Or the physical health provider doesn't have sight of how the trauma is making it hard for that person.
I'm sorry, Namita, you left that on me. Or you cut out for just a second. I see you now.
Sorry. So trying to get the team to enhance our processes for collaboration in addition to workforce education and training. Financing, which is a bigger fish to fry. Changing and considering alternative payment models and shifting from fee for service. Technologies, even our EMRs and our platforms aren't necessarily built in a way to foster integrated care. Care delivery, looking at the needs of the clinical, operational, and the finance, trying to put things together. Everything has to be looking at integration, and then population and community health. So one of the things that drew me to MCARA also was the focus on social determinants of health. And so having access to a community health worker who could go into the home and address some of the issues related to nutrition or transport or co-pays, and be a team member right there with the field nurse, with the nurse practitioner, with the MD, with the licensed clinical social worker, care manager who's providing counseling in-house, is huge. So I think that also is increasing access in another way, because we can take the care to them, bio, psycho, and social.
Yeah. And so you talked about integrated behavioral health from many different angles. Given that many of the folks in the audience today are, with a health plan, what role do you think the payer plays in sort of expanding access to integrated behavioral health?
I think they have a huge role to play in this space. As I mentioned before, we may all see the value of whole person, team-based delivery of healthcare, but there may be difference in readiness across the marketplace to integrate and different infrastructures and processes. It's a huge culture shift. And one of the biggest culture shifts, I think, is thinking not about behavioral health as a different service, a different product. It is part of the package. And as you're thinking about it as part of the package, you're not looking at cost effectiveness of behavioral health treatment. You're looking at cost effectiveness of integrated care. And that changes the lens, and that changes how you advocate for different types of payment models. So if you're in a fee-for-service, more focused sort of arrangement, it might be saying, what is the incremental change I can put in there to have some more prospective payment models, some PMPM in addition, that might incentivize provider groups being able to provide some pieces of integrated care and get incentivized based on value rather than on volume. And in the short run, some of the outcomes will be increased access and quality. In the longer run, there will be those outcomes of cost, and I'll give you a couple examples. So there was a study of cost effectiveness of embedding a behavioral health clinician in a primary care practice in, I think it was in Kansas City. And they embedded a licensed psychologist full-time in primary care. And they compared the individuals who had at least one licensed psychologist visit versus the rest of the population. And they looked at claims data 21 months prior, and then they looked at 14 months after. And they found that there was a cost savings of $860 per member per year. So over 10% savings in cost for those patients from just a licensed psychologist embedded in primary care. So I think it takes a little bit of shifting, because when you look at that, you're not expecting push a button and your costs are going to magically improve in 2 months. But it's a process of access and quality that then feed into those costs for the long haul. Another one, there was another study looking at an alternative payment methodology. It was SHAPE, Sustaining Healthcare Across Integrated Primary Care Efforts. It was a demonstration project. And it took 6 primary care practices in Colorado in this project, and had a behavioral health clinician providing services within primary care in 3 of the practices, and not in the others. And they compared the payment model in 3 of the practices was non-fee-for-service compared to the traditional model. And when they compared pre and post, so 9 months before and 18 months during, the folks who were in the alternative payment model that was non-fee-for-service, they had over $1 million in net cost savings for their public payer population. That's Medicare, Medicaid, and dual eligible, over 9,000 patients. And those cost savings were primarily through reduction in downstream utilization and hospitalization. So it is there. We have to try and figure out how to make more of a stronger business case. While there's a lot of literature out there, a lot of health plans and payers, they still want to see that, well, can we actually do that ourselves? Can we replicate that? And so I think it's on us to figure out how to make the case for different individuals, on the health plan side, to show them more, yes, there is this return on investment that you will see. And we may have some intermediary metrics to look at before we see the hospitalization shift. And then on also for the customer, the client, to be focused on access and quality and clinical outcomes.
Yeah. So you talked a little bit about, the connection of the intersection of behavioral health into primary care, and also the evolution of fee-for-service to value-based. What if a health plan already offers behavioral health benefits? Can you share any thoughts on how they may work within the existing resources to offer behavioral health and sort of evolve to sort of what you spoke about in regards to primary care and
Yeah,
value-based?
so there are different levels of integration. And so if a plan has behavioral health services, and I've heard it said before, we don't need to integrate behavioral health into primary care. We have the ability to get our folks plugged into behavioral health providers through the health plan. I said, that's great. Now, are those providers looping back and partnering and talking with the rest of the core team? Are there processes in place for care management, not just saying, oh, I'm going to refer to behavioral health? Are there ways to tailor what is the treatment that someone needs? We've had many times where people have been referred, and even the patient themselves doesn't know what they need. They say, I need X. And the health plan says, well, we don't cover X. And actually, when we go back and work with our behavioral health care manager and the core team, we figure out what this person needs is why. Let us go back and advocate for the health plan for the resources that they do have and why is covered, to be able to link the patient appropriately. And I think also thinking in the field of substance use and mental health in general, trying to shift to more measurement-based treatment to target. So for anxiety and depression, following and tracking screening, PHQ 9 and GAD-7 scores, and that will help to move people along a little bit more in terms of progress, rather than someone just starting a medication and then they may not get the titration that they need. And then a lot of substance use disorder treatment, we're trying to shift the emphasis so that what's covered is evidence-based. And the American Society of Addiction Medicine has different criteria that they are promoting, by which you can look at different treatment programs like residential programs and see, is this an evidence-based program? Because the health plan wants to know that they're getting value for their dollar. So those are some things. I think low-hanging fruit is trying to figure out, low-ish hanging fruit is more streamlining of care management support and interfacing with primary care groups in a more collaborative manner, rather than primary care groups pressing a button and, let's say, throwing a referral over the fence.
And so have you seen any innovative ways that health plans and providers are really delivering this integrated model to their members and patients?
Well, there are many different ways. It is the AIMS model in University of Washington, which was based on the findings of the IMPACT trial, that embeds a behavioral health care manager in primary care who is a licensed clinical social worker, a psych RN, or a licensed psychologist. We have adopted that model, and we are using a licensed clinical social worker who does in-house anxiety and depression counseling, and also helps with care management of more complex cases in collaboration with a behavioral health provider. The traditional collaborative care model had the care manager meeting weekly with a psychiatrist to review more complex cases, and using a measurement-based treatment to target approach following PHQ and GAD scores on a panel management tracker. That was a formalized tracker of how patients were doing. In our model, the behavioral health care manager in our market in Florida, where we're building this out, is working with me in terms of care management for the more complex cases. In some models, and also in that model, we are finding that people who are being referred for behavioral health resources, we're identifying, wait a minute, many of these people are complex also physically and socially. And bringing the team together and building more complex care or multi-condition team collaborative processes to wrap around the patient more effectively.
Mhm.
I've also seen models which are more like a FQHC based, where there is a psychologist on call, if you will. And so if a primary care provider is seeing a patient and there's an issue comes up, even something as simple as, say, needle phobia, and so they don't want to take their insulin because they're afraid of needles, they can call in the psychologist, and the psychologist can then transition and spend some time with the patient, working with them, and then the primary care provider can step away. So it frees up the primary care provider too to be more efficient in the use of their services. There's also that in their model, they have a 24/7 hotline that you can call a psychiatrist on call if you have a medication question. We in MCARA are also trying to build capacity by using a tech platform that allows us to get a rapid turnaround response from an online psychiatric consultation platform for things that we feel that are beyond our scope to handle, even with building education and training of our primary care teams and with our behavioral health care manager and support from me. And as I mentioned the other example there of the licensed psychologist in that study in Kansas. So there are a variety of ways. In the future, I'm also I'm looking at exploring increasing substance use disorder treatment and partnering with our pharmacy leadership to be able to enhance quality of care for substance use disorder. And I think there are lots of opportunities there if we can get access to the data and figure out how to track, screen, pick up, greater identification, greater HCC capture, and then quality of care and correlating with medications, pharmacotherapy, and psychotherapy, and trying to better meet our patients' needs.
Yeah. So I think just from a time check, we have, I'd like to ask one final question and then open it up to the audience to see if they have questions as well. So if you're out there and you're thinking of a question or you want to think of a question to ask, we'll open it up in just a few minutes. But my final question before we do that is, you mentioned early on some of the success metrics and some of the other studies that other organizations have done. I know just our work with the payers, they are very focused on, how do we measure success? And I realize this could probably be a whole webinar in itself, but can you say a little bit about how we can go about measuring the success of these programs, whether it's short-term versus long-term? And you hinted at some of those results from past studies. Any additional thoughts there?
First of all, good baseline data. So do we have accurate data and reporting measures to know the baseline prevalence of mental health and substance use disorders that are diagnosed in our populations? And then do we have screening protocols in place and ways of tracking how good we are doing in terms of screening and identification? I think one low-hanging fruit is increasing HCC capture by early screening, implementing more expert screening and brief intervention and referral to treatment for substance use disorders. And so that would be a lower hanging fruit in just screening and identification and then getting people linked in. Being able to have data to generate target lists, if you will, to be able to say, here are our highest utilizers of the emergency room and the hospital. How many of them have co-occurring mental health and substance use disorder conditions? And let us be more strategic in the energies that we spend to come together for joint treatment planning and interventions to move the needle with some of those folks who may be using the ER or the hospital inappropriately, and then tracking over time the pre and post for that. And certainly there are other opportunities in terms of behavioral health related HEDIS measures and looking at depression screening in that regard, looking at follow-up after admissions for behavioral health conditions. So a lot is contingent upon data and tracking and and having protocols and policies in place to be able to do that kind of pre and post work.
That makes sense. Well, thank you. We do have a question from the audience, so I'll go ahead and read it. And then, so when we're talking about integrated behavioral health in the home, are you talking behavioral health providers actually visiting the patient's home? Are you talking about virtual care delivery? So can you talk a little bit more about our model from Ankara Health when we're in the home? What does that look like from a behavioral?
That's a very good question, because our core teams in general, which consist of a community health worker, field nurse, a nurse case manager, an advanced practice provider, an APP, or a nurse practitioner or PA. In general, we try to encourage folks to go into the home because there's so much that you can get from being in the home and the building of the relationship face to face. In terms of capacity, given the limited resources in terms of behavioral health providers, we at this point, our model for behavioral health care management, which is in-house anxiety and depression counseling and additional care management support for other behavioral health conditions, is primarily via tele. So very occasionally we do in-home, but it's via tele, and sometimes it's one-on-one with the patient after the core team has given the patient a heads up, and framing it as, you're not going to a separate behavioral health clinic. This is someone who is part of our team. So we work with them and helping pave the way for the transition for them meeting with the behavioral health care manager who does an assessment. Mm-hmm. Sometimes that is also a telehealth assisted visit, meaning we can bring others in. So the care manager might bring me in. Or sometimes the nurse practitioner will say, I am having challenges trying to move things forward with this patient, or figure out what the options are and what to present to them for, what they're going through right now. Will you join me in a visit with the patient? And so we have those opportunities too, which is wonderful to increase access. And I think it's a huge opportunity where there may be issues with transport or rural areas for our providers to be in the home and to bringing others as needed.
Okay, thank you.
Does that answer your question adequately?
I think so. If there are additional questions or more to build on to that, feel free to type it in the chat box. We do have another question. So what advice do you have for those of us trying to make the case for implementing integrated programs and health plans?
I would say gather the literature out there for all your competitors who are doing this already. If you, and I don't want to frame it as this is what you're not doing, but here's what other people are doing, and here's the positive impact that they're seeing. And if you want to remain competitive in the market, as well as provide quality care, you will have to join the movement in some form or fashion. And if you're not quite sure how to start, consider somehow partnering with other collaboratives that are already maybe a little bit further along, and that sharing of that information so you don't have to think about it from scratch and it's overwhelming. Because some of these conversations about financing and what's the ROI, it's not as easy. I'm not just changing a medication from brand name to generic and I'm having a cost savings. I can't push a button and make someone's depression go away. And so, but that being said, cases have been made and people are doing it. You need champions in your organization, and they also have to get external support to show to their current partners and health plans, hey, this is what is being done out there, and educate the key stakeholders on the business side as to why different patient populations will have different levels of behavioral health needs. And if you choose not to pay for it now or integrate it, you will pay for it later, and you will probably be paying much more for it. So it's just continuing to get the message out there, and there's lots of data and literature out there online and collaboratives that have formed and resources like PsychHub that can give you additional mental health education capacity building support. So it's a little bit of wearing out the shoe leather, but you are not alone. There are others who are already doing this, and many who are doing this want to spread the word because they see the value for the patient as well as the cost savings for the long run.
Mm. Thank you. There was another question about, sharing some of the studies that you mentioned, which I think, we could gather links to that information or more on that to provide to the group if you want to dig in further. So I believe that was the last question. So with that, if there are no other questions, thank you for such an engaging conversation today on such an important topic. I definitely feel your passion coming through, and there is a need for this type of work and to really integrate behavioral health into care delivery. So thank you. I thank you, Ron, and I will turn it back to you to close us out.
Thanks very much. I'd like to thank the attendees for taking time out of their day to join us. I'd also like to thank Allison and Namita for a very informative webinar today. Just a reminder that the slide deck and recording will be posted on the ACAP website by tomorrow morning. So with that, I'd like to say have a good rest of your day and stay safe.
Thank you very much. Bye-bye.